Thank you. I hope you can hear me.
Yes.
Great. Well, it's a great honor to be invited to present here to this International Meditation Expo by Dongguk University. I'm coming from Cambridge, Massachusetts, here at Harvard Medical School. And I'm going to talk today about mindfulness as a transformational practice for living well. I want to spend a moment to just talk about the center that we developed starting in 2014, called the Center for Mindfulness and Compassion here at Harvard Medical School and as part of the Cambridge Health Alliance. The mission of the center was to enhance the health and well-being by integrating mindfulness and compassion into healthcare and our communities with a commitment to inclusivity, accessibility, and diversity, and to cultivate mindfulness and compassion in patient care, in professional education and training, to conduct rigorous scientific research, to understand workplace well-being and burnout prevention, and to focus on how to make mindfulness accessible for our diverse communities. Since 2014, we've grown, now have more than 80 staff, faculty, or volunteers affiliated with the center, and 30 staff members conducting research, patient care, professional education, and training. I want to tell you about some of the work that we've done at the center over these past 8 years. But I want to start by first talking about how we think about mindfulness and its benefits. This is one of many websites I've found that lists off all the benefits of mindfulness, that it relieves stress, reduces anxiety, improves sleep, takes away pain, it will improve your mood, boost energy. Mindfulness does have that impact for many people when they practice. But I think more than any one of those individual impacts, I think it's most important that we focus on the ways that mindfulness practice can really transform the way we live. In the introduction, they talked about the 2,000 years of history of mindfulness and meditation and the reasons why people practice. And today in modern times, we're promoting a lot of these reasons on the left for why people practice. But over the past 2,000 years, people have practiced to be able to change the way they live and to be able to have greater compassion and connection in their community. So I want to talk a little more about that. And what does it mean for mindfulness to be a transformational practice? A transformational practice is an intentional activity that someone commits to for an extended periods of time with the purpose of empowering change or supporting transformation. With mindfulness, we see that transformation can happen on multiple levels. There's the individual transformation in the way we live. It can transform the way that we relate to others, the interpersonal level. Within organizations, we've seen now mindfulness practice and meditation practices beginning to impact organizational structures and functions. And I think as these kinds of conferences that you're holding here today and the work that everybody's doing together, we may be able to start to have more transformational impact on society, perhaps even addressing any of the structural inequities or challenges that lead to ongoing suffering for populations that are minoritized, and to look at the potential for transformation on a global scale. So I want to start by talking today about the Mindfulness Training for Living Well curriculum that we developed at the Center for Mindfulness and Compassion here 8 years ago, and talk about it because it's designed to help people learn how to warmly be with their present moment experience. And through that, building the capacity to live intentionally and to allow transformational change on the individual and the relational levels. So mindfulness training for living well focuses on health behavior change and chronic illness self-management. So why does it focus on that? Well, health behavior impacts our overall well-being. Health behavior can prevent chronic illness if you have healthier, if you reduce unhealthy behaviors and increase healthy behaviors. Then once people have a chronic illness, self-management of that chronic illness through behavior change and adherence to medical regimens, whether it be diet, exercise, activity, medications, sleep, or self-care practice like meditation, can improve health, can extend life, and also reduce costs in the healthcare system. We know that ongoing unhealthy behaviors can lead to multiple chronic illnesses, and these unhealthy behaviors can also have impacts on relationships, organizations, society, and the world. So if we want to start to have a transformational impact in all those levels, it starts by focusing on helping people to reduce unhealthy behaviors. And when people are living with chronic illness, it can affect their mental state, which can then lead in a reciprocal relationship to impact their mental health. And that can impact their capacity for self-regulation, and ultimately can lead to people with chronic illness feeling disempowered and like they're not able to care for themselves. So that's why we focused on this as a core focus of a mindfulness-based intervention. Just to reiterate this, if you look at the major causes, preventable causes of death, the diseases that are related to preventable causes of death in the United States, they all are linked to many modifiable behaviors. Similarly, as you can see here on the right, the United States in particular has had a lot of difficulty with people avoiding pain or dealing with pain through opioids and other drug-related deaths, which has led to a lot of drug-related deaths. And so our work at the center has focused in on trying to address that behavior change that might be needed to turn around some of the morbidity associated with these chronic illnesses, as well as with the opioid crisis. I believe that we've gotten the attention of our healthcare systems because of the impacts it has on patients and patients' health, but also because unhealthy behaviors are the key driver of health costs, especially in the United States, where 1 in 5 adults use tobacco, 1 in 3 adults are obese, either from a mix of overeating or inactivity, and people consume alcohol excessively with the costs that you can see below. And overall, the chronic illnesses, many of which are preventable or modifiable by behaviors, actually account for about 80%, 86% of US healthcare costs. So we tried to start with our own area. This is, as you can see, a map of Cambridge and Boston on the East Coast of the United States, the Northeast United States in Massachusetts. This is Harvard University, you may have heard of it. And we are located here in Cambridge, next to Harvard. And our healthcare system, the Cambridge Health Alliance, is the safety net healthcare provider for this area of the Metro North Boston area for 5 cities north of the river here in Boston, from Cambridge out to the ocean. And there are 14 primary care sites across that region that are managed by our healthcare system. And we have historically been the system that's taking care of the poor and disenfranchised members of the communities. And we felt that if we could integrate mindfulness into our healthcare system at the level of primary care, which is the heart of the healthcare system, that it could bring mindfulness throughout the healthcare system and create a more healthy and holistic way for all the patients in the region. What we designed was a program called Mindfulness Training for Primary Care, which uses the curriculum and the mindfulness training for living well and makes specific adaptations to allow it to be a referral-based insurance reimbursable program in the US healthcare system. So it was developed as really the first implementation of a referral-based insurance reimbursable system. So we've had more than 4,000 referrals from primary care providers across our system for patients to these 8-week groups. And we held groups regularly every quarter in Cambridge and Somerville, as well as out in this region, which in Malden. And the groups were designed to enhance chronic illness self-management, reduce stress, anxiety, and depression while motivating behavior change. And we recognized early on that when you ask people to stop and pay attention to what's present for them, for many people, actually what comes forward for them are past traumas or pains that they've been carrying in their body from things that have been going on, or they become aware of the structural traumas that are ongoing from poverty, from racism, from discrimination. And so it was really important to design a program that could be trauma-informed and safe for people who would be, if we're going to be doing this in the healthcare system. I'm happy to see that the mindfulness-based program movement has now been really integrating a more of a trauma-informed and trauma-sensitive approach into the work, and that's really critical to the work what we're doing. Just want to say that in addition to all the roots of that our intervention, our program has deep roots back 2,000 years in Theravada Buddhism, in Mahayana Buddhism, in Zen, and these are the more modern roots from which we've drawn our mindfulness training for primary care program and our mindfulness training for living well curriculum is adapted from MBSR that was developed by John Kabat-Zinn and the folks at UMass Center for Mindfulness. But we consider this a third generation mindfulness-based intervention. So what we did was we looked at all of the second generation mindfulness programs, like mindfulness-based cognitive therapy for depression, mindfulness-based relapse prevention for addictive behaviors, and work that was going on related to mindfulness for addictions by Judge Brewer and by Eric Garland in mindfulness-oriented recovery enhancement, as well as the innovative work from one of our faculty members, who you'll see later today, Chris Germer, around mindful self-compassion, really trying to create a third generation mindfulness-based intervention that can move the data and the science forward, that integrates the best practices from all of these around behavior change, as well as learnings from the history of working with DBT, internal family systems, which you'll see. You'll meet Dick Schwartz later today or tomorrow, another one of our faculty members, as well as some learnings from acceptance and commitment therapy and motivational interviewing. So what we've tried to do is create a mindfulness-based intervention that builds on the history, 2,000-year history, the history of MBSR and MBCT, and that brings in all of these other innovations as well to create a third generation MBI. So what's the structure of MTPC? Well, the first 4 sessions are very similar to MBSR and MBCT and focus on cultivating mindfulness. And then sessions 5 through 8 section 5 focuses on kindness and coping. And for those that know the curriculum of MBSR, you know that this is often something that comes in session 7 of MBSR, or something like this about kindness. And we try to bring this early because we need to be able to be kind to ourselves before we can make lasting change. Otherwise, people start to try to make change, and then the self-criticism can actually keep them from being able to make change. So we bring in kindness and coping early, and then we focus on accessing core values and understanding aspiration for change. We then talk about living well through wise action and the concept of being skillful in one's choices and means of change. And then finally, one can't really make individual change without understanding the way that our behaviors are connected to others, the way others have a stake in our behaviors, and being able to communicate with others and our community about that change. One of the things that's unique about MTPC is that there are 3 threads that are brought throughout every session. In addition to the regular standard mindfulness-based intervention threads. And these 3 additional threads that we added, and we find a place in every session to start to develop these threads developmentally over time, is developing warmth and a sense of common humanity, really developing that capacity for interpersonal mindfulness, and also connecting what we're learning in every session to behavior change. I'm just going to share a few core concepts that are unique to MTPC, but that I think are really helpful, are concepts and practices. So one of the core concepts is the diamond of experience. And we use this as a way of thinking about both pleasant and unpleasant events as we're teaching mindfulness, with this idea that every experience, every situation triggers or activates a cascade of thoughts, emotions, physical sensations in the body, as well as an urge or a behavior if you don't notice the urge. And at the heart of all of those is the valence or the feeling tone. And what we teach and show in our groups and help people realize is that if people can be able to notice any of these experiences, any of these parts of the diamond of experience, and just warmly be with that experience, whether it's in the body or noticing the thought as a thought, or noticing the emotion as an emotion, or even noticing that there's an urge. And especially if we can notice the feeling tone of pleasantness or unpleasantness, then that gives us the window into stopping the cascade in the mind. And that's where we're able to start to regulate and be able to have more self-agency in what's happening in the mind and in our bodies. Just like other 8-week mindfulness-based interventions, we have an informal practice. So there are formal practices, which are things like the body scan or breath meditation or a loving kindness meditation, for instance. But the informal practice here was developed and adapted from the 3-minute breathing space of MBCT and the self-compassion break in the mindful self-compassion program. And the way that this works is we teach this and build each session. We build on a new letter and help develop through these skills so that by the end, people have all the skills they need in one practice that can help them to work with whatever unpleasant experiences might arise, or overly pleasant experiences that might arise that they might get attached to. One other thing that we built into this is that the theory is that people often end up in habitual behaviors because of avoidance. There's a term called experiential avoidance. And it means that when people are uncomfortable, they tend to want to avoid their experience. They want to look at their phone. They want to work harder. They want to go drink or smoke or binge watch on Netflix. And part of being able to change that habit is to move from experiential avoidance to learning how to warmly be with present moment experience. So that's what this program, which we call Stop, Ache, and Go. Stop, allow yourself to feel the ache, and then go. So this practice is trauma-informed because it allows people to recognize over time what's most skillful for them. But it starts with stopping. And if you can't stop what's going on, just slowing down and trying to turn towards experience, this kind of physical shift towards trying to be with what's present for you here. And for a lot of people, that's hard. So you can take notice of breathing, or take notice of the sounds in the room, or take notice of your feet on the floor, depending on what's skillful for you right now. And then trying to turn towards experience again and observe what the mind is aware of now in this diamond of experience. Observing with openness, thoughts, sensations, emotions, urges, and really noticing the pleasantness or unpleasantness or the neutral feeling tone of the present moment. And just allowing it to be as it is. If there's an ache, if there's discomfort or unpleasantness there, just accepting that the ache is here. Sometimes it's really hard to allow an unpleasant moment to be as it is in its fullness. And for those who find it hard, we encourage people to make skillful choices about anchoring to the present, either through the breathing, again, through sounds in the room, or through the feelings of the feet on the floor. And for many people, as they are trying to allow or be with the ache, there can be a lot of tightness or unpleasantness present. And this is a moment to have compassion for oneself, to bring compassion to the parts of the body or the parts of the mind that are suffering, not because we want the feelings to go away, but because all beings have suffering. It's a common humanity of the experience of unpleasantness and suffering. And because we are a being, I am a being that is deserving of compassion because I'm suffering. So we are able to bring compassion and warmth to the parts of the body or to parts of the mind that are deserving of it. Or if we're really caught up in the pleasantness of a situation, in the excitement of it, in the pleasantness of some sensation or sensual experience, a way to, it's an opportunity to bring curiosity and really get curious about why this sensation is captures us so and creates such attachment. As we move through this practice, we can hold the experience with warmth. And for many people, maybe bringing a hand to the heart or hugging oneself, or even practicing some soft, gentle touch can elicit a soothing response and can be a way that we can care for ourselves to help us to hold and stay with the challenge or the ache for a bit longer. Then from there, we invite participants to expand awareness from the area of the body where there is an ache, back to the breathing, then to the rest of the body, and then out to all of the senses. And then we invite people to have a moment of gratitude. When we are finding ourselves in difficult situations, we often can feel very alone and like we're not sure what to do. So to be able to have gratitude that there is something we can do, that we have our practice. And then from there, to really reorient towards how we want to be and how we want to live in our lives, and grounding in our core values, which become like a foothold. Or if you imagine climbing a wall getting a nice foothold to be able to push yourself up in the direction you want to go. And then from there, we open to life's challenges, its beauty, and work to orient towards present moment experience with kindness. What we're doing in this informal practice is trying to bring together all of the wisdom in thousands of years of different meditation practices into a single practice that people can learn and develop and integrate, that can help them not just reduce anxiety or reduce stress, but really be able to help transform life. So one of the biggest questions that comes up is relating to change. Why we're not trying to change something because part of what we're doing is trying to allow ourselves to be with present moment experience. So one of the questions is, how can you have a behavior change intervention or program if it's all about allowing us to be with present moment experience? So that's this reconciling, non-striving with the need for change, that we want to align our lives with our deepest values. We also need to realize that everything is changing. Everything changes. It's changing all the time. We actually need to let it change. Part of what happens is we get caught in conflicts internally. We get caught in habits and reactions. And we actually don't let the changes that are naturally happen. We see things through our filtered reality instead of being able to see the natural changes that are happening. So if we can start to see things with the beginner's mind again, see things as they are, we can see all the changes that are there and then actually let it change and allow those changes to start to emerge. We can set aspirations and intentions in a just right way. Aspirations like an egg. If you hold the egg too tight, you're going to end up with yolk on the floor because it's going to break. If you hold it too loosely, you're going to drop the egg and end up with yolk on the floor. You need to hold the egg just right. And when you do, you can hold it for a long time and it won't get broken. So setting a mindful aspiration, setting a goal in that just right way is an important skill so that we're not striving or rejecting ourselves or trying to change through shaming ourselves, but we're setting an aspiration and starting to move in that direction in a just right way, and learning through skillful goal setting how to set goals with inner kindness. So the study that we conducted from 2014 to 2020 was a randomized comparative effectiveness study comparing 8 weeks of mindfulness training for primary care versus what's been the standard, which is a low-dose mindfulness comparator. MTPC was 2 hours long for 8 weeks with a 7-hour day of silent practice delivered by mental health clinicians or primary care providers in primary care clinics and billed as group psychotherapy or medical group visits with about 10 patients. Our low-dose comparator was a 60-minute introduction to mindfulness and then referral to community mindfulness resources, the top mobile apps, the classes, books, websites that were available in the community. And we called everyone every 2 weeks and encouraged them to practice mindfulness so that it would be attention matched. They'd get a similar amount of attention and encouragement as those in the 8-week program. And we randomized 2 people to mindfulness training for primary care for every 1 person to the low-dose comparator. Our first goal was to make sure that what we were doing was accessible. For too long in the US, mindfulness was primarily being something offered to upper middle class folks, often who are white and English speaking, with high levels of education and income. We wanted to show that by putting this into the healthcare system at the level of primary care and making it insurance reimbursable, that we could make this accessible even for the poor or the disenfranchised in our communities. And we were able to do that. We met our goals of having at least half of the people be on subsidized insurance. More than 60% had less than $40,000 in annual income, and 37% were either non-white or had English as a second language. So we were able to do this for 2 different studies and demonstrate that this was accessible. One of the main outcomes that I'm going to talk about today was what we called our action plan initiation survey. So we asked people in our groups, in both groups, both arms, to set a goal that was specific, measurable, that they could agree on, that was realistic, and that was time-based. So it had a time limit of 2 to 3 weeks. And so, or 2 weeks, sorry. So, and then we asked people at 1 week, at 2 weeks, and then at 3 weeks, what was the goal you set? Was it related to activity level, exercise, diet, eating, drinking, or self-care practice, or other goals? What was the goal? And did you meet that goal in the last 2 weeks? And we a priori set that anybody that said that they had a 5, 6, or 7 around meeting that goal was somebody who initiated their action plan. And one of the things we're looking at in our study was, would there be differences between the 2 groups in who would initiate a behavior change within 2 weeks of setting a goal? So you can see both groups, they did an orientation, they did surveys, they were randomized. We offered some patients an opportunity to participate in fMRI, which is magnetic resonance imaging of the brain to look at brain activity. And then at week 7, we had them set an action plan. And then we looked at week 9 and 10 to see, and 8, 9, and 10 to see who initiated their goals. And we also did some imaging afterwards as well. So these are the data that we have from the first 2 studies that we did. The first study was a pilot study with 81 people. And you can see here that people who were in MTPC had 4 times the odds of initiating a health behavior change or chronic illness self-management goal within 2 weeks compared to the low-dose comparator. We did it again with 136 people in a study that was monitored by the NIH, National Institute of Health here in the United States. And we improved our processes for encouraging people to initiate action plans across the board through video about SMART goals, about the goal setting. And you can see here that still we saw about 2 to 3, almost 3 times the odds of people being able to initiate a behavior change within 2 weeks. You can see the red here. People are much more likely in MTPC to initiate a behavior change than the low-dose comparator. So one of the things that we were looking at as part of this study was trying to understand, how does mindfulness impact self-regulation to help cause behavior change? This is a paper that we published as part of our collaborative network in the Harvard Review of Psychiatry. That's an overview of a narrative review of all the literature focused on mindfulness and behavior change. So I recommend it. And what we found was that there's evidence for mindful self-regulation in emotion regulation, self-related processes, attention and cognitive control, as well as systems for motivation and learning in the brain. And these are all the different areas, I'm not going to go into it today, where there's some evidence that mindfulness may be impacting these systems in the brain or the body or the mind to then help people impact behavior change. We were particularly interested on how mindfulness might improve emotion regulation using the difficulty and emotion regulation scale, as well as the ways that interoceptive awareness, changing the people's relationship with their body and the way they regulate body signals might impact. And this is the multidimensional assessment for interoceptive awareness. So this is our 3rd study I'm going to talk about. Our main aim for this study was to look at emotion regulation. That was the primary aim. And we also wanted to replicate the action plan initiation outcome. And then the overall project with NIH, we had set out that our main aim was to really look at the role of interoceptive awareness, or the awareness of internal body signals as a potential mediator of behavior change. And specifically interoceptive appreciation, which is the ability to listen to and trust your body and value what you are noticing in the body as part of behavior change. So that's what I'm going to talk about now. You can see here in the third study that we enrolled 99 people, randomized 95, 62 to MTPC and 32 to low dose comparator. We actually had to end this study early because of COVID-19. On March 14th, actually both South Korea and Boston, where I think the two of the areas that first started to experience a lot of COVID-related changes. And so we had to shut down the study, but we were able to include 49 people in the analysis prior to COVID and 24 in the low-dose comparator. So you can see here, actually, there were no difference in demographics between the two groups in this study. There was a difference here in depression with actually more depression, higher percentage of depression in our low-dose comparator. So we did control for this in the analysis I'm going to show you. So this is the change in emotion regulation scale. The difficulties in emotion regulation scale are called the DIRS. And you can see here that in the MTPC group that there's a much more rapid decrease in this difficulties in emotion regulation scale that's maintained both at 8 weeks, that's maintained at 24 weeks compared to the low-dose comparator. And you can see here, if you look at the subscales of the DIRS, there were 3 that our intervention seemed to really be engaging. So one was that people seemed to have more emotion regulation strategies. They were more able to, they had less difficulties around emotions related to goal-directed behaviors, and they had greater ability to accept present moment experience or emotions. And that seems to be what was driving the improvements in emotion regulation. We also found that there were, again, almost 3 times the odds that people in that MTPC group would initiate an action plan within 2 weeks compared to the low-dose comparator. So we've replicated this now in 3 studies. The odds ratio here is nearly exactly the same in our last 2 studies, suggesting that this is a consistent finding and that MTPC really does increase people's odds of initiating behavior change. So you can see here all 3 studies where we looked at this and the really similarity between these last 2 studies as far as the impact on the odds ratio. We also looked at baseline in this population among 281 people, looking at how depression severity was related to interoceptive awareness, and that people, as they were more depressed, were more likely to not feel safe or trust their body sensations, and therefore were less likely to listen to their body sensations when they're depressed. And if you think about depression as a state of lacking motivation, it makes sense that as people are more depressed, they're not listening to their body. They're losing access potentially to their body sensations that they need to motivate them into action. So we started to think about this idea of body listening and body trust representing something we call interoceptive appreciation, recognizing that our body wants to tell us something, but we have to listen and trust what it's telling them and value what our body's telling us. I'm going to talk for a minute about a neuroimaging study where we start to look at this. So we took 41 participants from Mindful PC, the Mindfulness Training for Primary Care study. We we excluded some people because there was head motion or people didn't complete post-training visits, but we ended up with 28 participants, 14 men and 14 women who were in the final analysis. They had a history of major depressive disorder, dysthymia, or anxiety disorder. And you could see here that we had an interoceptive attention task where we asked, which I'll show you below. And we had people do the task before. They did the 8 weeks of the intervention, they did the task again. And the task was relatively simple. We had people focus on sensations of their heartbeat, noticing their heartbeat in the body, and then rating the intensity, and then paying attention to an external stimuli, looking at the word target, which would switch from capital to lowercase. And they would count how many times it switched. So this is internal body sensation, and this is an external body or external sensation. We did that 18 times. And looking at the difference in the brain during this task, which we felt like was a measure of interoceptive attention. And you can see here that after training of 8 weeks in mindfulness training for primary care, people were more likely to have an increase during interoceptive attention in the insula, which is an area of the brain that's involved in regulating and experiencing internal body sensations. And you can see the increase here in the insula from baseline to post-training. Well, we want to understand the way that this might be impacted by depression, as well as the changes through the intervention in interoceptive awareness, interoceptive appreciation. And what we found was we had 2 subgroups. So we had people with anxiety and moderate to severe depression, and people with anxiety alone, without depression. And what we found was that depression moderated the association between post-training change in body trust and brain response to interoceptive attention here in the insula. So as people became more trusting of their body sensations, among those who were depressed, they had more, they'd increased activation in the insula during this interoceptive attention task. So people with depression seemed to be becoming more trusting and were able to have more activation in this area of the brain. Whereas the people without depression, mainly the folks that were anxious, didn't have that change. So we also looked at this mediation model, so thinking about how does mindfulness training for primary care impact action plan initiation or behavior change, and how much of that goes through interoceptive appreciation, the change that people have in their ability to listen to their body and to trust and feel safe with their body sensations. So what we did was we looked at all 3 studies that had people completing the interoceptive awareness measure. And out of 270 people that were randomized, 183 were randomized to MTPC and 91 to low-dose comparator. 141 completed the baseline in 8-week Maya, and 65 in the low-dose comparator completed the baseline in 8-week Maya. You can see here the demographics were actually the same between both groups. There were not the differences that we saw in the third, in the third study. When you look at all 3 studies together, there were no differences between groups. And what we found in our mediation analyses was that MTPC increased change in people's ability to listen to their body for guidance, and that change in body listen predicted their ability to initiate a behavior change. So it was a partial mediator. We also found for body trust that people's increased trust in their body increased their likelihood of initiating a behavior change. This is huge because if you are practicing meditation, you know that starting to tune into your body, starting to feel body sensations helps give you wisdom about what might be right for you to do and helps you to initiate behavior change, and also to stop certain behaviors that just don't feel right, or that you know in your body feel like they're conflicting with your deepest values. So part of MTPC is also doing a core values training exercise. We'll go through many different values and see what the feeling of each value is in their body. And so the idea is to help people get used to feeling their body and using it as a source of wisdom for how they might live. And so when we look at the two together, if we put both into the model together, both body listen and body trust, what we saw was that actually both are engaged. Although it was more so for the whole sample through body listen than body trust. So we got very interested in how this might change with depression. And we conducted a moderated mediation in 3 different groups: those with no to slight depression, those with mild depression, and then those with moderate to severe depression. And what we found was that the strongest pathway for those that had no to slight depression was through body listen. That these changes, for those that had no to slight depression, MTPC impacted body listen, increased people's capacity to listen to body, and that had a very strong effect on people's ability to make a behavior change. In mild depression, it was actually about half and half. It had MTPC had a similar effect on body listen and on body trust, and both had an effect on action plan initiation, which was not significant, but that was largely because this was the smallest sample. So we were underpowered to really find a difference in the mild depression part of the moderated mediation. But when you look at moderate to severe depression, you can see that MTPC did increase both body listen and body trust, but the change that we're seeing in action plan initiation in MTPC among those with more moderate to severe depression was through changes in body trust. So I'm just gonna share some conclusions and try to explain some of the data that I showed. So what we've been able to show over these 8 years is that MTPC is implementable in a diverse safety net healthcare system, is accessible to socioeconomically and culturally diverse population in primary care. MTPC supported primary care patients with anxiety, depression, and stress related to living well with chronic illness and helped them initiate behavior change and chronic illness self-management behaviors. MTPC improved emotion regulation, especially related to acceptance of emotions, goal-directed behaviors, and emotion regulation strategies. MTPC increased insula activation during interoceptive attention tasks among primary care patients with anxiety and depression. And the change in the insula during interoceptive attention tasks was largest among those with depression who had an increase in body trust. We also showed that this idea of interoceptive appreciation, which is the ability to trust what your body's saying, to listen to it for wisdom, and to value your body's signals, actually partially mediated the effect of mindfulness on behavior change by helping people trust the body and listen to body signals that motivate change. The combined indirect effect of interoceptive appreciation of the two together was greater than either individually. And among those with depression, body listen alone, among those without depression, body listen alone was a significant MTPC mediator, API mediator. But in those with moderate to severe depression, body trust was a significant MTPC API mediator. Therefore, in depression, feeling safe in and regaining trust with the body may be a key step on the mindful path towards change. We offer our groups the Mindfulness Training for Living Well curriculum every 3 months through CMC. And you can see here, you could register for, if you're interested, for the program on our website at chacmc.org. We also have every fall a mindfulness training for primary care group leader training. We're doing these live online in November. So you can see the dates here in case you have interest. You can go to our website and look into that. I have a lot of gratitude to express. This program was initially supported by the Cambridge Health Alliance, the Arthur Vining Davis Foundation for a Healthcare System Transformation Grant, the Gold Foundation for Humanism in Healthcare, and then was supported by the NIH Science of Behavior Change Initiative and the National Center for Complementary Integrative Health. We've had an incredible team. And as you can see, over 8 years, we've had many people, many great scientists and team members and group leaders working with us. I want to point out Todd Griswold and Richard Gawande, who have been with this project from the very early days, as well as co-investigators who helped with analyses, Tim Creedon and Ben Cook. Our neuroimaging team has been excellent with Dr. Napido, Desbordes, Datko, and Jacqueline Lutz. We've had so many wonderful and committed research coordinators and research assistants. And as you can see here, this study took really the commitment of more than 16 MTPC group leaders who were trained to be able to implement this across the healthcare system. I'm grateful for all of the collaborators in our Science of Behavior Change Initiative to help us conceptualize these questions. And especially Eric Lux, Willoughby Breton, and Jean King, who were the multiple PIs for the NIH grant. And then all of our collaborators, both within our healthcare system and internationally, as we've worked to translate our program into Portuguese, as well as into Spanish with our collaborators from Brazil and Spain. So that's the end of my presentation, and I'm available for questions and answers.
Yes, thank you very much for your insightful lecture. I really enjoyed listening to your presentation. 건강하고 즐거운 삶을 위해 만성 질환과 스트레스를 관리하고 마음 챙김을 강화하여 건강한 커뮤니티 연결을 도모하는 웰빙을 위한 마음 챙김 훈련을 강의해 주신 제브 올리비에 교수님 다시 한 번 더 감사드립니다. 지금부터 Q&A 세션으로 들어갈 건데요. 먼저 첫 번째 질문 드리도록 하겠습니다. 심리 상담가 치유사들은 남을 돌보다가 자신이 지치기도 합니다. 남을 돕는 것은 좋은 일이지만 다른 사람과 자신의 웰빙 치유를 어떻게 조율해 나가는 것이 좋을지요? 라고 첫 번째 질문 왔습니다.
So when we actually started this program across our healthcare system, we started by training providers. So we initially offered an MBSR program for 40 primary care providers and did trainings at an hour-long mindfulness training at every one of those healthcare sites before starting to offer it to patients. Because I think that you're right, it's very difficult for healthcare providers to help people heal in this way and transform their life in this way if they are still caught up in unhealthy habits or behaviors themselves. Healthcare providers can help heal many acute illnesses very well. And we have some medical treatments and other types of treatments for chronic illness. But honestly, modern medicine has not been great at helping people manage chronic illness. And I do think that as healthcare providers, as therapists, as clinicians, it's important for us to be able to develop this kind of wisdom with mindfulness, this kind of practice, so that we can help our patients understand how to make the changes that they know they need to make. In fact, in our first study, we partly why we had slightly lower rates of initiation was we asked people to not just set a goal, but to talk to their primary care provider about that goal and make sure their primary care provider agreed to that goal. And it turned out that 49 out of 50 people who set a goal, they knew what they needed to do before they talked to their primary care provider. Only one person, changed their goal because of the discussion with their primary care provider. People knew what they needed to do. they didn't know how to do it. And they felt too stressed to do it. And so what MTPC did was create the space for them to be able to do it. But what a healthcare provider can do is learn how to warmly be with their patients and what's coming up for their patients from moment to moment. And in doing that, I think it can make space for their patients to share what's really happening, or what really is holding up the behavior change. I remember when I was a medical student, I went to a new primary care provider and I walked in, and when he was taking his history, he said, "You don't use drugs or have unprotected sex with people, do you?" But the way he said that was so invalidating and shaming that if I did, I never would have told him. And I think as providers, when we can become comfortable with ourselves, when we can use mindfulness to accept ourselves or allow what's here for us to be here, we can actually make more space to be able to really be with all the different parts of our patients, so that we can realize there are no bad parts of them. Shame is a major reason for avoidance behaviors. And one of the reasons people end up in repetitive cycles of harmful behaviors. So we need to try to find a way to take the shame out of behavior change. And that's a big part of why we looked to the Mindful Self-Compassion program to bring more self-compassion and self-kindness into our program, because it helped people to be able to, if you can be kind to yourself, then you can survive looking at the shame and then looking past the shame at what's under there that's waiting for healing.